Dear participants, my name is Gab McDonough, and I'm the Educational Action Supporting Officer at ERN-EuroBloodNet, the European Reference Network for Rare Hematological Diseases. And it is my great pleasure to welcome you to ERN-EuroBloodNet Thursdays Webinars. The aim of these educational activities is promoting the interest on very innovative topics in order to stress among health professionals the cutting-edge advances in the field of rare hematological diseases. Webinars are mainly addressed on very rare diseases, complex disorders, highly specialized procedures, and implementation of guidelines. At the same time, webinar programs that are specifically addressed to patients tend to increase the awareness on specific rare hematological disease, patient advocates, and patient associations. Before we start, let me share some home rules. Please note that the session is recorded and will be uploaded in the EuroBloodNet e-learning environment. If you do not wish to appear, please turn your camera off and change your name on the platform. Also, be kindly informed that your microphone is muted. If you have any question about the presentation, please write them in the chat and they will be addressed during the Q&A session at the end of the webinar. And with that, today's webinar is entitled, When is Molecular Analysis Useful in Myelodysplastic Syndrome? And our guest speaker today is Professor Valeria. Professor Valeria Santini has been an associate professor of hematology at the University of Florence, Italy since 2000. Professor Santini runs the MDS program at the hematology unit at the AOU Careggi Medical School, University of Florence, and her interests are in translational research in MDS and AML. She is a member of the Medical Advisory Board of the Aplastic Anemia and Myelodysplastic Syndromes International Foundation, AA and MDS-IF, and is also the president of ISF in Italy. He is also an author of more than 250 peer-reviewed papers published in international journals and has been an invited speaker at numerous international meetings and conferences. Her accomplishments can't be summarized in simple paragraphs, but it's a great pleasure to have you. Thank you so much for joining today. Professor, the webinar on the platform are yours. Thank you very much for joining.
Thank you very much for this very kind introduction. My task today is to share the last views on the use of molecular analysis in myelodysplastic syndromes. These are my disclosures. And I just want to start with an old slide, just to set the point that somatic mutations are extremely frequent in MDS, more than cytogenetic alteration, so that together cytogenetic alteration and mutation account for 95% of patients. Very recently, there has been an upgrade of the classification of MDS. So there is a long story complicating the classification of MDS. And in 2022, two parallel classifications came out. And why am I presenting you these? Because both classifications, the WHO one and the ICC, included in the classification the recognition of MDS classified only on the basis, or mainly on the basis, of molecular alteration, namely, as you see in the red square, SF3B1 mutation and TP53 mutation. And this is true also for the ICC classification. They differ in some way, but this was a common feature of the two classifications. Before this classification, there was a combined effort led by the group of Matteo Della Porta, to which we participated as well, integrating somatic mutation in the prognostic evaluation of MDS, completely agnostic of other features like clinical or let's say molecular or cytogenetic modification. And as you may see, it was anyway possible to stratify patients in categories with significantly different prognostic features. But in 2022 was also published what is now broadly used, that is the IPSS molecular prognostic system. this system included hemoglobin, platelets, and bone marrow blast as clinical variable. Neutrophil number was not significant, therefore was not included. The old IPSSR cytogenetic categories, and 17 binary features derived from the presence of mutation in 16 predictive genes here listed, plus one feature of additional mutation from a group of 15 genes. These are the most frequently mutated genes, and these are they have a different prognostic weight. This allowed let's say the building of a prognostic score system that was available for all patients and applicable for all patients is a continuous risk score. It's patient specific, and what is more important is reproducible and very well interpretable. And the IPSSM stratify prognostically patients with MDS in 6 categories correlating with leukemia-free survival and overall survival. But what is also very important, and I will come back to these during my presentation, is the fact that IPSSM compared to IPSSR, in which molecular categories were not present, frequently upgrades the prognosis. And as you see in this slide below, patients who were classified low and very low according to IPSSR are upgraded to high and very high risk according to IPSSM, meaning that we should then modulate our approach to this patient depending also on IPSSM categories. And here again, if you compare IPSS, the old prognostic system, to IPSSR, and then to IPSSM, you see that these are high-risk patients. You have a progressive upgrade of the risk of this patient, so that even some patients who were classified as IPSSR intermediate are in fact belonging to very high risk according to IPSSM. I just want to stress that IPSSM is evaluating the prognostic weight of single mutation and their combinations and presence. So it gives you a very sophisticated way to evaluate the prognosis of this patient. Very more rarely, the patient with an IPSSR very high can be downgraded. This IPSSM was validated immediately after publication on big numbers of patients, here almost 3,000 patients with primary MDS obtained from 21 European centers. And you see here which were the most frequently mutated genes. And you also can extrapolate here the fact that 82% of patients had more than one somatic mutation in 31 genes indicated by the IPSSM. So you see, even in real life, and this extensive real-world validation shows that the categories, the 6 categories, are maintained, both for overall survival and leukemia-free survival. And even if you have patients in which there were not detectable IPSSM indicated gene mutation, you can still have a decent and valid prognostic evaluation. Now, what about patients receiving treatment, and especially disease-modifying treatment? Unfortunately, IPSSM cannot stratify the risk for patients and the prediction for patients receiving hypomethylating agents, but can indeed be a very solid support for the prognosis of patients receiving hematopoietic stem cell transplant, as you see here. Now, there is still the problem of the 2 classifications that should be harmonized. So a big effort, of a combined effort of many centers overall globally mainly in Europe and US, brought this data. So you may imagine that these data were available for around 7,000 cases with somatic mutation and with clinical data. And what came out from this huge study are some defined group with specifically clinical characteristic of outcome. And indeed, MDS patients with the mutation of SF3B1 classified for both the two WHO and ICC classification as MDS SF3B1 had the best outcome, with a leukemia-free survival exceeding 8 years. Of course, there are some slight difference, but the percentage of patients with this into this category accounts for 12% around of the entire MDS population. MDS with del(5q), it is an apart category that was also present in WHO 2016. It's also a category characterized by favorable outcome. It's rare, 5% of all MDS cases, and the median leukemia-free survival is around 6 years. What is really in a category with worst outcome is the category of MDS with biallelic TP53, that for the ICC is categorized together with AML as MDS-AML with mutation of TP53. And this is, in fact, we will see later, an apart category. Now, all this effort brought to a very simplified category. So when we diagnose an MDS, we check for presence of biallelic TP53. If so, MDS is a MDS with biallelic TP53 inactivation, and it's an apart category. But if there is del(5q) alone, or with another additional chromosomal abnormality, with the exception of monosomy 7, and there are no blasts, we have the category of MDS with del(5q). If there is if there is no del(5q) deletion and the presence of SF3B1 mutation with, again, the absence of the cytogenetic categories with worse outcome and prognostic value, like deletion of 7q. If ranks 1 mutation are absent, we can classify MDS with mutated SF3B1. The blast count are more than 5%, then we have MDS with increased blast, and if not, and no other mutations are helpful, we have morphologically defined MDS as MDS with low blast. So a simplification and a sort of challenge by my good friend, Professor Comroci from the Moffitt, is that we could do a conceptual classification of MDS. A chronic phase 1, the categories with good prognosis, accelerated, the ones with blast or biallelic TP53, or MDS, we didn't talk about this, with MDS with fibrosis. But if you have AML, even if the morphology reminds you of MDS, but you have more than 20% of blast, or you have AML cytogenetic or gene mutated that are defined as AML-like, then you are in a complete different category that could be defined as blast phase MDS. And this is what we know for somatic mutation. But in WHO 2022 and in ICC 2022, there has been a widening of the consideration of germline mutation. The germline mutation were considered mainly in the past for the syndromic cases, whereas now we know that this number is quite wide, and that's why this is a new scalable model in which we can introduce other mutation in the moment that we establish the pathogenicity of these mutation. So as you see here, and as you see in the list by ICC, these germline predisposition mutations are very numerous. And what about it? Because do we know when the MDS appears in this patient with germline predisposition? Actually, it's very variable, and it's not only in very young or pediatric age, but there are some mutations like DDX41 that are present in earlier age, but do become manifest clinically in older age. So a patient who develops an MDS over 7 years can be a patient with a predisposition and mutation of DDX41. So we, in our center, we try to understand whether it was worthwhile to study molecularly the patient younger than 60, so the younger MDS patient, because the age is in Europe is 74, the median age is 74. So the ones you wouldn't expect to get MDS being de novo MDS and not therapy related. We performed in 31 consecutive case exome sequencing from bone marrow, peripheral blood, and check, and for the majority of patients, check with saliva. And what we saw was that in 22%, nearly 23%, there were germline mutation that were likely pathogenic or pathogenic. And in 29% of cases, there were germline VUS. So indeed, it's a phenomenon, the predisposition, that is much more frequent than what we thought. Now, what do we do about all this data, molecular data, for therapy? Can we apply some of our knowledge to modify and optimize therapy? There are several, I would say many agents that have been explored for treatment of MDS. Not many of them, especially for high-risk MDS, have been successful, and extremely few of them are really targeting specific gene mutations. So in my mind, there are at least 3 possible approaches to optimize therapy of MDS based on molecular characterization. The first one is to try and target a single mutation. Now, I already showed you this slide, but here I show you in green the rare mutation of IDH1 and IDH2 genes, and in blue, the rare mutation affecting tyrosine kinase in MDS. So these are possibly druggable mutations, and we should find a way to use them in MDS. Now, the mutation in activated kinases, as I mentioned, are extremely rare in MDS. We do have the inhibitors of FLT3, like midostaurin, sorafenib. We have the ponatinib for the mutated patients who have this possibility to be treated, but we do not have many patients with MDS can take advantage from these mutations. In fact, they are much less than 10% altogether. Now, I showed you that IDH1 and IDH2 are mutated around in 3 to 5% of cases, mainly high risk. But the importance of this mutation is quite relevant because a mutation on this gene leads to accumulation of 2-hydroxyglutarate. That is important and relevant modulation of epigenetics and facilitate let's say, the development of neoplasia. Now, this mutation leads to metabolic deregulation, but the most important thing is that we can target it because there are 2 drugs, and especially we'll be interested in IDH1 mutated inhibitor, ivosidenib, and can be used in MDS. This is a very interesting study led by the French group of MDS that enrolled patients with MDS, high and low risk, and IDH1 mutation. So there were 3 cohorts. Cohort 1, high-risk MDS, who failed azacitidine treatment and were enrolled to receive ivosidenib, that is an oral drug, for 6 cycles, and then response was evaluated. Cohort B, high-risk MDS, with acceptable white blood cells and hemoglobin, that had never received treatment and could be treated in the beginning with only ivosidenib and eventually could receive an additional treatment with azacitidine. And again, here, after treatment, the patients were evaluated. And then the very small cohort C of lower risk MDS who failed EPO and received 6 courses of ivosidenib. Now, I just want to show you the response. So the patient who relapsed after azacitidine achieved response in 64% of cases, but the ones who never received any treatment and in almost totality of the cases were treated with only the oral drug ivosidenib achieved overall response rate of 78%. So azacitidine, as I mentioned, was added after 3 cycles only in a minority of cases. And as you see, unfortunately, the patients who were refractory relapsed to hypomethylating agents had a median overall survival of around 9 months. But the ones who responded after ivosidenib and had not received any previous therapy had a median overall survival and a duration of response that were not reached, with a follow-up of 25 months. This super small group of 3 cases with low-risk MDS. 2 of the 3 achieved CR. All 3 were kept on therapy for several months, but it's too early to conclude anything from this data. And I want to stress the fact that the majority of patients with IDH1 mutation and low-risk MDS are mainly neutropenic and more rarely anemic. On the other hand, ivosidenib has been approved in mutant IDH1 relapse refractory myelodysplastic syndromes with a very good response, CR of nearly 39%, overall response rate of 83%, with a median duration of response not yet reached. So I think that this is a way to go, targeting a specific somatic mutation. But we can also use the base to choose our best therapy based on the molecular pattern of the MDS patients. And this is something we observed in our lab, and the manuscript is in submission. The patients who have higher risk IPSSM have lower probability to respond to erythropoietic stimulating agents. Of course, this is useful because you can spare treatment that are not effective and have to be kept for a long time, even if there is a simple treatment with ESAs. So we may use IPSSM not only to prognosticate the patient, but also to choose therapy. And this is particularly true if we consider patients evaluated by IPSSM who are candidate for allogeneic stem cell transplant. And this is something I want to walk you through. It has been published recently. What we may do, integrating clinical and genomic data of patients to support the decision of the timing of transplant. As you see from in the left panel, from left to right, in younger patients, in purple, you have patients with low-risk MDS and moderate low-risk MDS according to IPSSM. These patients do not have advantage in an early transplant in terms of overall survival. Whereas in red, if you have a patient with very high IPSSM, the more you wait, the less advantage in terms of overall survival you can get. So this is particularly true for younger patients and for patients up to 66, whereas for elderly patients, the risk of transplant is anyway quite high, but it still shows that if you wait too long with a very high IPSSM risk, you will end up in losing probability of in advantage of survival. And compared to IPSSR, indeed, it is clear that there is a need to change a transplantation policy according to this model, because the probability to gain survival, it's higher if you regulate and modulate access to transplant according to IPSSM. Finally, there are some mutations that may confer enhanced sensitivity to some therapy. And of course, we immediately think of the association of molecular alterations with the response to some factors. The first of all, luspatercept, that is used and approved for treatment of anemia of low-risk MDS patient, both RS positive and RS negative, but we know from early studies and from confirmation studies later on that patients with SF3B1 mutation, and many of them being ring sideroblast positive, are the ones who respond better to luspatercept treatment. This is why the medley study was designed like that, including only MDS-RS patients that in more than 80% of cases do have SF3B1 mutation. Compared to placebo, luspatercept was extremely active in inducing transfusion independence longer than 8 weeks, and even in a long-term follow-up study maintained this activity. As you see, if you consider a long period of treatment, nearly 48% of patients achieved transfusion independence for cumulative periods, and very significantly more than the placebo. So we do not know yet exactly why luspatercept works so much better in patients with SF3B1 mutation. The mode of action of luspatercept is to trap ligands of activin receptor 2B, and therefore blocking SMAD pathway and SMAD phosphorylation, and inducing late erythropoiesis, stimulation of late erythropoiesis. It has been used also in patients who were not refractory to erythropoietic stimulating activity agents, but were anyway lower risk and transfusion dependent. Again, was compared to erythropoietin because this is the treatment of choice for this subset of patients. And it was shown that it is much more active in this subset of transfusion dependent patients, much more than EPO. And if you see in this slide, 70% of patients with SF3B1 mutation achieved a TI response, so a transfusion independence. A little bit less if this mutation was not achieved, but was not present. But in a longer follow-up, this delta, this difference seems to be less for the non-mutated patients. Finally, I added another point, a fourth point. Possible molecular markers of response are the variant allele frequency of the somatic mutation. There is another drug that has been approved in the US for treatment of transfusion-dependent low-risk MDS because it's active in compared to placebo in transfusion-dependent patients with high transfusion burden and lower risk. And again, the primary endpoint is transfusion independence equal or longer than 8 weeks. And as you may see, it is much more active than placebo. But what is interesting is that it's keeps this activity if we reclassify this IPSS lower risk patient with IPSS-M. So you still have much more response with imetelstat than with the placebo, even for the very rare recategorized high and very high IPSS-M risk patients. What is also very interesting is that the response correlates with cytogenetic response, but mostly with variant allele frequency reduction of the somatic mutation present in several patients. And as you may see, SF3B1 mutation, TET2, DNMT3A, and SXL1 decrease significantly in terms of variant allele frequency when the patients are treated with imetelstat, indicating most probably that this therapy is modifying the natural history of the disease. So we may use this somatic mutation and their quantitative presence in terms of, let's say, witnessing the efficacy of the drug. Now, I already mentioned that TP53 mutations are really defining a different subgroup of MDS. We should treat MDS and AML with TP53 mutation in a complete different manner from other MDS and AML. It's a world apart, in fact. Several years ago, we showed that the type of TP53 mutation, in fact, denotes a different prognosis. So the patients who had one allele mutation of TP53 have an overall survival and a degree of AML transformation that is superimposable to patients who do not have TP53 mutation. But when the TP53 mutation is biallelic, then the inactivation of the protein is complete, and then both survival and AML transformation are significantly different and worse. Even the overall survival and response to lenalidomide is modulated by the presence of biallelic or monoallelic TP53 mutation. And unfortunately, all the therapies that have been attempted for TP53 mutant MDS-ML, let's talk in this term, have shown dismal outcome. 15–20% CR if we treat with hypomethylating agents, especially azacitidine. Actually similar to what we observe in TP53 wild-type patients. Many of the patients, even if they achieved a response, then they lose it. And the overall survival, of course, it's much shorter than that of wild-type high-risk patient. There is no improvement in this patient if we add to azacitidine or decitabine venetoclax, and I'll show you the data. Maybe for the patients who have blast and monoallelic TP53 subclone, a small subclone, maybe intensive chemo can still be considered, although we know that they do not respond well. What about transplant? For many years, we have debated whether it was worthwhile transplanting patients with MDS and AML with TP53 mutation. As a matter of fact, although hematopoietic stem cell transplant in these cases is not super successful, these patients do have a survival at 3 and 5 years that is around 20%. So not really a very successful result, but if we do not transplant them, the overall survival is even lower. So this very interesting paper of 2 years ago already, it's pointing out for the necessity of considering transplant in this subset of patients. I told you, treating with oral decitabine, cedazuridine, that is stabilize decitabine molecules and therefore possibly increase its effect. You see, leukemia-free survival is 22 months in low and high-risk TP53 mutated patients, and overall survival is around 2 years. But when you separate the monoallelic with the biallelic, you still see that the dismal outcome is for the biallelic with only 1 year overall survival in the best responders. So to conclude, is it useful to assess somatic mutation and germline mutation in MDS? It's true that the level of anemia shapes the symptoms, but in fact, the characterization of the disease is very complex. We have to take into account family and patient history, comorbidity, geriatric assessment, metabolic situation. But I highlighted the fact that it's becoming more and more important to evaluate by next generation sequencing somatic and germline mutation for the reason I just showed you during my lecture. What is the future bringing us? Of course, implementation of artificial intelligence in our evaluation of so many data, clinical, genomic, and transcriptomic, to reach a personalized prognostic assessment in cancer, in neoplasia, as rare as MDS. So you see, you put together genomic features, clinical features, the analysis and evaluation based on artificial intelligence can bring us to a different classification. Now, last month, Elisabetta Sauta presented very nicely this data in an approach called MEGA-ERA. Again, this is an approach that requires collaboration of many centers and many cases. This approach wanted to put together not only the next generation sequencing evaluation for the traditional classification, but patient's genomic profile, genetic abnormalities, but also immune-related features and transcriptomics all together. So we will have patient data and integrate with even the morphology and the digital pathology, clinical data, omics data. Artificial intelligence will fuse all this data, and then we will possibly have a complete and more sophisticated evaluation of patients' prognosis and disease characteristics so that we can tailor a better therapy. This is the name, MEGA-ERA, from a goddess era. It's a, as you see, multimodal, explainable, and grounded artificial intelligence-based engine for research advancement in personalized care of hematologic neoplasia. So this is our future. So we will have to cooperate, work together, put together omics, histopathologic and morphology data, as well as genomic data, and reach a personalized approach. Just to show some of the result of this very nice work that was driven and led by Matteo Della Porta, is the sensitivity, as you see, of the MEGA-ERA integration that is much higher than the IPSS-R and the IPSS-M in terms of overall survival risk prediction, but also in terms of response to hypomethylating agents. So we will see in the future what we can bring to the bed, from the bench to the bed of the patients. But in the meanwhile, I thank you for your attention, and I'm ready to get all the questions that you can have. Thank you.
Thank you very much, Professor, for that excellent presentation. It's wonderful. As mentioned earlier, if you have any questions, this is a great time to put them in the chat. I will read them out loud, and then Mr. Santini will have a chance to answer them. We can start off with the first question that we have here in the chat. For patient MDS at high risk for allogeneic transplantation, what bypassing regimen do you use? AZA, AML, therapy?
It depends. It depends on the general condition of the patients, and the bridge to transplant can be effectively obtained by treating with azacitidine and venetoclax, only azacitidine. Intensive chemo, I do not favor intensive chemo unless the patient has a normal karyotype. As I mentioned, otherwise we do not obtain so many response, but also the use of the liposomal anthracycline and cytarabine combination. Now, there is also the possibility to avoid therapy to bridge to transplant in patients who have less than 10% blast, but maybe they have a high-risk IPSSM, and they can go straight to transplant. This is an approach that we do have in our center for selected patients, of course.
Great. Thank you very much for that answer. Thank you for that question. We have a thank you from the person that asked the question. Thank you. Once again, this is an excellent chance to ask Professor any questions that you have regarding the subject matter. In the meantime, let me just make a quick announcement for the next Thursday webinar, which is on the management of relapsed refractory acute lymphoblastic leukemia in adults on February 6th at 5 o'clock. And the speaker will be Nicholas. So we hope that you can join as well. Once again, if you have any questions, please feel free to add them into the chat. We have another follow-up question. How do you characterize the sensibility of genomic studies on salad tests?
Now, what I said is about luspatercept. Is it so? Because I don't hear so well.
Sorry, I can repeat it.
On salad test, sorry, I cannot hear you very well.
Oh, sorry about that.
So what we have done, we have checked the germline, the germline nature of the mutation we tested in patients in blood and in bone marrow by testing saliva, but not only. We also tested hair, DNA obtained from hair, to be sure that it was not a somatic mutation, but a germline mutation. Saliva was chosen because this study was set up several years ago, and we had this urgency to conclude the study, and not all the patients were available. The best comparison anyway would be on skin, DNA obtained from a skin biopsy. So for our studies now, we privilege small skin biopsy to check for germline mutations, for the germline nature of the mutations.
Great, thank you for that question, for your answer. We have another question. Timing of transplantation in low-risk MDS not responding to ESA or have low EPO?
As I showed you, the patients who are not responsive to ESAs but do not have high-risk disease should not be considered for transplant, because the risk-benefit balance is for risk. As I showed you, even if you are young and you are transplanted too early, your overall survival is not increased, and opposite can be decreased. Of course, you may consider some patients who are heavily transfusion dependent, and then, but these patients usually do not have a low risk. Whereas for low risk patient, now you have other options of therapy, and you can try these before trying transplant.
Great, thank you very much. And it looks like there was a clarification in the question just afterwards saying do not have low EPO, which I believe you addressed.
Low?
Do not have low EPO was the person's clarification at the end.
Do not have low EPO, sorry. Sorry.
No, that was a clarification afterwards, so.
Okay, so but if they have low EPO and do not respond, we still have other options of therapy before thinking to transplant. And I must say that I'm very careful in proceeding to transplant too early for the risk I just mentioned. You may consider it if the patient has several mutation and a high IPSSM risk. But otherwise, I would be very careful, and it depends on age, general conditions, comorbidity. So this is very important. Before going, if the patient is only anemic, I would be very cautious in running to transplant.
Great, thank you very much for the clarification and for your answer, Professor. Once again, we have time for other questions, so feel free. This is a wonderful opportunity to have such a distinguished professor here at your disposal. So feel free to add any questions in the chat. Perhaps we'll wait 1 minute. Professor, I was very happy to hear you talk about the future. Just having, seen some of the presentations from Saverio and Elisabetta, it would be great to have everyone together. I think that's very exciting for this field.
Yeah,
so.
it's an excellent group. They're really running to the future, and their data are really outstanding. And what is important, and it has been stressed many times, and I want to stress it again, is that if we work all together and we put all the data together, we may be quicker in achieving results.
Right.
And this is what I do.
Perhaps we can get all three of you together for a webinar. 3 great minds. It would be wonderful.
Nice, nice.
Okay, I will ask one last time if there are any other questions from our attendees. And if not, I would like to thank you once again, Professor, for your excellent presentation, for your time, your expertise, and your generosity. Thank you so much. Thank you so much who asked several questions. So on behalf of EuroBloodNet, I would like to thank you once again and wish everyone a wonderful evening and a happy new year. Thank you.
Thank you very much. Bye-bye.